aspart and blue lysine. And also now we have another discovery of ultra rapid acting insulins, which is more rapidly acting than the routine regular rapid acting insulins. That is fast insulin aspart. So it's the most recent discovery, and it has its own set of advantages. Then on the other spectrum of the insulin, we have another that's very long acting insulin, which we call it as insulin dip. So I'll not be covering much on the other insulins. I'll be covering more on the ultra rapid acting insulins and the very long acting insulins and how we can use them in our routine patients. So this graph, I think all of us are well aware. So this shows the onset and the duration. So as all of you know, regular insulin, usually the half-life is around 4 to 6 hours. The intermediate acting it is 10 to 12 hours, or up to 14 to 16 hours. And then long-acting ones, largely, it is up to 24 hours. Now coming to the newer insulins, that is the rapidly acting insulin, that is aspart, lispro, and blue lysine. Then they act within 15 to 20 minutes of the injection, and the duration of action is around 0 to 5 hours. And inhaled insulin is still in the pipeline, but as of now, we are discussing rapid acting insulins. On the other spectrum, the ultra long acting insulin, that is U300 glargine and insulin dip. You can see here the action is a very smooth acting, very long acting, and they act even up to 36 hours. You can see here, compared to the other insulins, there are no peaks. So these advantages makes it more useful in the setting of a long-acting insulin where there is no risk of hypoglycemia. So this slide is very important for you, where I just focus the important points regarding insulin aspart. So fast-acting insulin aspart is a new formulation which mimics the physiological prandial insulin release more closely than the regular insulin. So what does this mean? So this insulin fast-acting aspart mimics the physiological prandial insulin. As you know, whenever we take food, immediately there is some amount of insulin released from the pancreas, and that will take care of the prandial excursion of the glucose. So just a small question to all of you. When is regular insulin given to a patient? Like if you want to give a regular acting insulin, when do you usually give? 3 minutes. So we have to give around 15 to 20 minutes prior to the food. But the advantage of this insulin is this insulin can be given even at the first bite of the meal, or even within 20 minutes after starting the meal. So do you think this can be advantageous for any group of patients? Yes, because we have many patients in our ward who are ill, who are suffering from various infections, who are having vomiting, who are doubtful whether they can consume food at that point of time. And also in the hospital loaded with patients, many times we have seen sisters running around the wards with some time logs, and patients will be waiting to take their insulin, and sisters won't be coming to administer them. So in all such settings, and even here, if at all there is a doubt that this person can take or not, you get 20 minutes of regular acting insulin. What if you vomits immediately after taking the food? So there is no hypoglycemia. So in such uncertainties, we can use this fastest acting insulin, which acts immediately at the first bite and within the 20 minutes of starting the meal. So one thing, going back to the physiology, so this action mimics the physiological action of insulin. So it's like how the natural insulin acts in our body. The moment the food is taken, the insulin starts getting released from the beta cells. So similarly, it mimics, and hence the efficiency of this insulin is very good compared to the regular acting insulins. The pharmacokinetic characteristics of insulin faster aspart have the potential to better reproduce the fast endogenous prandial insulin secretion and thereby improve the postprandial glucose control. Any doubts in this aspect? I think it's clear. So coming to the insulin dip is an ultra long-acting basal insulin. So what does basal insulin mean? So it doesn't have a peak. Takes care of the basal aspect, that is the fasting hyperglycemia is well controlled. But thing is, it won't take care of the excursion. So for excursion, we need to give a primary insulin, which is either regular acting or ultra short acting insulin. So it's a basal insulin. It has duration of action that can last up to 48 hours. Compared with the 18 to 26 hours provided by the other long acting insulin, such as large molecule. Insulin Dip product has an onset of action within 30 to 90 minutes. So this year, you should remember it acts in between 30 to 90 minutes, and its action lasts up to 48 hours. But usually it takes around 2 to 3 days for the insulin Dip product to get stabilized, the levels of insulin to get stabilized. It is also comparable with glargine and vitamin. There is no peak in its activity due to the slow release into systemic circulation. The durational action of Icu is reported as being longer than 24 hours. So this is one of the big advantages of insulin Icu. Compared to glargine, Icu is associated with equivalent HbA1c control and significant lower nocturnal hypoglycemia rates. In type 1 diabetes or type 2 diabetes insulin name, Icu is associated with significantly greater rate reductions in the glucose, and also the requirement of total insulin is much less. So just a few advantages of how it is better than the regular glargine insulin is that it has no peak, very long duration, has very smooth duration of action. According to the studies, the risk of hypoglycemia is very, very less. And also the total dose requirement of insulin when glucagon is given is also much less. So these are few of the advantages of insulin. So now, coming back to the original topic, barriers to achieving glycemic control in hospitalized patients. So what are the barriers? Like why can't we achieve the proper glycemic control in our hospitalized patients? There are three issues faced mainly by doctors. They are very much scared of hypoglycemia. Yes, we are definitely worried whether the patient can have hypoglycemia. So this needs to be reduced for a proper glycemic control. Compared to the nursing. So coming to the nursing domain, nurses usually have high patient load. So they have to address the timings, like when to give insulin, when to order food, and so that the patient gets insulin and they consumes this food. Timings of injections and meals has to be adjusted. And for patients, for this variable calorie intake. So we are not sure whether this calorie intake is uniform as they have advised, or if some patients have ended comes with some food and they give them to it out without proper monitoring of the sugars. So all of these have to be monitored. And few system-related issues that usually in all patients, glucose is not a part of quality control measure in most of the hospital, but it should be considered as one of the important quality measure of the patient care. And rest things are, as I had mentioned, and also the comorbidities. And comorbidities can adversely affect the insulin levels and can cause hypoglycemia. So management of hyperglycemia in hospitalized patients. So usually in hospitals, what you do whenever the patient is admitted. For example, if patient has admitted with UBM, she has HbA1c of around 9, sugars of around 250. What do you do? What do you do between boards as of now? You will get rid of basal polarization also. Anything else which was followed earlier, which we strongly discourage from sliding scale regimen is what was followed, because we all felt that sliding scale regimen is very easy and we can give whenever the sugar is high. But there have been scientifically a lot of flaws in the sliding scale regimen, and now we have to address them with other safer regimens. So hyperglycemia and mortality has a very good relation. So they have a study done in the European journal. The European countries was shown that the mortality rates with normoglycemic patients was much less compared to the patients who had hyperglycemia, and especially if they have newly diagnosed hyperglycemia, the mortality was much higher. So the inference is that when hyperglycemia is generally associated with increased mortality. So the basic thing should be in all the admitted patients should see that the sugars are under control. So this is one of the very good study which I wanted to explain. So the association between glycemic variability, length of stay, and mortality. Since many of the students are there, you people know what does glycemic variability mean? Even? So what was happened is, since we were students, we were told that fasting blood sugar is very important. Then some studies told that postprandial is very important. Whether the diabetes are well controlled or not. So nowadays, as per the newer guidelines, the newer studies, they have told that even better than HbA1c is something called as glycemic variability. So what does glycemic variability mean? Is the excursions, the sudden highs and lows in the insulin, in the sugar profiles of these patients. So many studies have shown that this glycemic variability, the more it is, then this more adverse outcome, even short-term outcome as well as long-term outcome. So glycemic variability is something which we have to address. So you will ask me that how to calculate this glycemic variability. So it's a very complex thing. What is being told is that frequent monitoring of sugars and monitoring blood sugar levels and we have to plot it against the graph, and we have to calculate something called as glucose standard deviation and glucose coefficient of variation. So basically, these two measures are nowadays being advocated as one of the best measures of good glycemic control. So this study was done to see what was the outcome, the change in the length of stay and mortality risk at 90th day. It was seen that people who are having more BMI had a more adverse effect. It was not related to the study of the sugars here. Hypoglycemic attacks. So the more the hypoglycemia, the more was the length of stay. More hypoglycemia, more was the 90-day mortality. So this point you should take on that. You should see to that we do not allow patients to become hypoglycemic when they are admitted in the wards. Then coming to the glycemic variability parameters, that is glucose standard deviation and glucose coefficient of variation. Both of them have told that if they are well under control, then it will have a favorable impact on length of stay. So to treat with that, whenever patients are there admitted with high sugars, we should see to that they do not go into the extreme range. They should not be that okay, morning sugar are 400, evening they have gone into hypoglycemia. So this variability should be avoided. So we should manage such a way that not find instance which will address this glycemic variability. So take home points from this slide is that glycemic variability is very important parameter to determine the length of stay as well as mortality risk. And hypoglycemia does have very bad adverse effect on the length of stay and the mortality risk. So now coming to managing hypoglycemia in hospital settings. So anti-hyperglycemic agents, generally once patients are getting admitted, we do not give oral antidiabetic drugs, we shift them onto insulin. So what type of insulin, whether it should we give IV insulin or subcutaneous insulin? So for generally critically ill patients in ICU, IV insulin is preferred. And for ward patients who are non-critically ill, subcutaneous insulin is preferred. So now coming to the targets. So this we all should be aware. Till now we were following RSSTA 2016 guidelines where for ICU patients the glycemic target was 140 to 180. And non-ICU patients, fasting was aimed at 80 to 120, pre-meal of less than 40, and post-meal of less than 180. So now the ADA has given a new guidelines in 2021. They have told threshold for starting insulin in ward patients should be more than 180. So any patient who sugars are more than 180, they need to start on insulin. And we have target the glucose around 140 to 180. And for patients, 110 to 140 for selective patients, if this can be achieved without hyperglycemia, without causing hypoglycemia. So 140 to 180 is very much good control for the normal ward patients. And healthy patients who are terminally ill and who require more of supervision, even higher glucose ranges are also acceptable. So according to the ADA regime. So take home is that target should be 180. From 140 to 180 should be our range. And for elderly and vulnerable population, you can go slightly higher levels. So anti-hyperglycemic treatment in hospitalized patients in non-ICU patients. So patients who are admitted who are unable to take orally or who are unable for oral, we can give them basal insulin, and there can be correction of insulin regimen, which can be given for some excursions in the daytime, which I'll be discussing later. And patients who are eating well or have good nutrition intake, we have to give basal insulin, we have to give prandial insulin, and we have to give correction components. So basal is a long-acting, prandial is a short-acting. Sliding scale regimen is once again strongly discouraged. So this was a nice slide which is portraying how the sliding scale regimen can be more worsening. So this graph you can show that the days of therapy and the blood glucose levels. The first one denotes the sliding scale regimen. There you can see that there has still not, there is no good glycemic control with the sliding scale. Whereas in basal bolus regimen, the control was much better. Even here, the readings before this line indicates that the sliding scale regimen was given, and the blood glucose went on increasing in the study, and it was published in the Journal of Diabetes Care. Whereas once with the basal bolus regimen started, the sugar control was much better. So insulin regimen for managing hyperglycemia in non-critical settings. So sliding scale regimen is outdated and discouraged. So there are two explanations to given that why sliding scale should not be used. It is a non-physiological but retrospective reaction to blood glucose levels. So this word I want you to concentrate that it is a retrospective reaction. So now already sugar has gone up and they are just reacting to it. So it is like that. So it's a non-physiological method and it's a retrospective action. Poorer glycemic control and increased risk of hypoglycemia is sliding scale. Even though we tell that it prevents hypoglycemia, but in studies it was shown that with the sliding scale, the risk of hypoglycemia was much more. Promotes glucose. This is called as roller coaster. You can see that like a roller coaster ride. This can happen if we use sliding scale regimen. And as I mentioned, that we have to prevent the glycemic variability. And this takes for a toss if we are using sliding scale regimen. And it is not for individualized, it's not linked to anyone, but we are not correcting it with the comorbidities or all, it's not individualized. And finally, it's a reactive approach practice. It's just a reactive approach. We are not scientifically treating the patients. So this is how it acts if the sliding scale regimen has been started. So despite increasing evidence that supports intensive glycemic control, the blood glucose level control is challenging, and sliding scale coverage practice which has limited therapeutic success is still being practiced in many hospitals. Even though more than 8 years without much evidence, it is still used. But all of the studies have told that it has little evidence of poor glycemic control and deleterious effects if sliding scale regimen is used. So basal bolus regimen is superior to and efficacious compared to sliding scale. It is a physiological way of glycemic control. So this you should remember, physiological way. So now you should remember that normally all of us there is some amount of basal insulin secreted, which will take care of the fasting glucose. And whenever the food is consumed, there is a prandial rise in insulin levels also. So basal bolus is a physiological method of addressing this condition. ADA has also recommended basal bolus regimen. So what does basal bolus contain? It's very important to post that. So takes care of the mean time and correctional, that is unexpected glucose elevations dispose of elevated hyperglycemia. In spite of basal bolus, there can be some excursions which the correctional dose has to be taken care of. Implementing basal bolus therapy to manage inpatient hyperglycemia in non-critically ill patients will improve sugar control. So now, basal bolus regimen has effective glucose control, lower risk of hypoglycemia. It is still flexible and it has simple dosing, and its usage is in the wide range of population. So this is important. I just asked a question: how do you make a basal bolus regimen? How do you calculate that? So this I just like I'm given a good formula to find out how to do a basal bolus regimen. There are steps. I think you can use these steps in your day-to-day practice. So step one is calculate the total daily dose based on the body weight and other patient characteristics. So first we have to calculate the total daily dose. How to calculate the total daily dose? So there is a formula here. For underweight patients, older patients, and patients on hemodialysis, this has to be 0.3 units per kg body weight. For a person with normal body weight or normal BMI, if you feel that the thing should be, the formula is 0.4 units per kg body weight. For overweight patients, it is 0.5 units per kg. For obese, insulin resistant, and patients on glucocorticoids, this can be even higher of more than 0.6. So we'll take an example. If a person is around 60 kgs who has normal BMI, so what is his total body total insulin requirement? 60 into 0.2, that's 24. So now we have to get this is the total daily dose of insulin. Now divide total TDT equally between the basal and 50% of the prandial. So it's only 24. Then 12 should be the basal insulin and 12 should be the prandial insulin. So in that 12, the bolus insulin is equally divided between the three major means. So what should be the bolus now? So 444 will be the prandial insulin and 12 will be the basal insulin. So this is a scientific way of calculating the basal bolus regimen. Then measure the sugars 4 times, that is 3 pre-meals, which is done in our hospitals. This is something which is slightly tricky, that is measuring insulin sensitivity. So here we are accounting to the other comorbidities. If you feel that this patient is insulin resistant, so how do you tell patient is insulin resistant? If he is obese, if he is on glucocorticoids, if he has hypothyroidism, or if he has even chronic intermittent stage, they can be insulin resistant. So in such conditions, if at all you feel that in spite of giving the basal bolus, there are excursions, so we have to correct it with additional insulins, like this is the range given here. For 100 to 140, there is no requirement. For 141 to 180, you have to add 4 more units at each meal. And likewise, as sugar increases, the amount of insulin requirement increases. So this has to be given only if there is no control in spite of basal bolus. and we are suspecting the insulin resistant states. Any doubts in this? Got understood. So how to calculate the Polish regimen and how to calculate the basal insulin dose. So coming to the insulin decrease, effective glycemic control. So the fasting blood sugar levels, you can see here all the levels. It is male patients, patient who was switched, who had short stay and long stay. The decrease was used. There was much better insulin control, and even the average plasma glucose was much better in the decrease group compared to the other insulin groups. So this is an interesting slide I want people to concentrate here. So low glycemic variability with decrease. So imagine a person with a sugar of 237 at the time of admission. So now, as per the glycemic variability rule, his glucose should not go above 300 or should not go less than 150. This is what we planned. So if the decrease was when the insulin decrease was given, you can see that gradually the glycemic variability came down and the sugars never went even higher or even lower. And that range of the 1/3 of the permissible limit of the standard deviation, the sugars were well controlled. So at the time of discharge, you can see that mean sugar was 150 and its p-value was less than 0.001. So the decrease shows the better predictability in wide range of hospitalized patients. So this glycemic variability expressions are much lesser if the ultra-long-acting insulins are used. Similarly, compared to the faster aspart which we have mentioned, so in all the group of patients, there was the better control of HbA1c, even the fasting sugars was much better. Faster aspart given 20 minutes post meal provides similar HbA1c reduction versus insulin aspart. So coming to the risk of hypoglycemia when the decrease was used, up to 40% to 50% achieved the mean glucose level of less than 140. Only one nocturnal hypoglycemic attack was observed in one of these studies. So it was seen that most of the patients, blue indicates that the sugars were around 140 and orange indicates that they are around 180. So most of the patients achieved the adequate glycemic control without significant risk of hypoglycemia. So this was an interesting study which quoted the risk of hypoglycemia with insulin faster aspart. It was seen that E represents the number of hypoglycemic events totally in a period of 1 year. Compared to the regular faster aspart, the hypoglycemic events were much lesser. So here it was 16 here and here it was 13. And this difference, both nocturnal and daytime, the hypoglycemia. So significantly lower risk of oral and nocturnal hypoglycemia with faster insulin aspart. This is also another important thing which you can address here. So flexibility in case of daycare procedures, decrease and what is its utility. So here you can see day 1 decrease was given, day 2 decrease was given, on day 3 patient was planned for a surgery. So even if the patient is planned for a surgery, there is no need of stopping the insulin. You can still administer decrease previous day and there will not be any risk of hypoglycemia during the study, during the surgery. Is as per the paper published in this journal. So stable glycemic profile and no patient undergoing surgery experience hypoglycemia during the fasting period of 24 hours decrease. So what it means that decrease will not cause hypoglycemia even if the patient is being taken up for surgery. So decrease can be used safely prior to the procedures requiring NPO with the least risk of hypoglycemia. So flexibility. So insulin aspart is more convenient in daily life, allows more precise calculation of dose based on carbohydrates consumed. So once the patient has consumed the food, you can give it the insulin. It's the biggest advantage. Reduced risk of hypoglycemia should a meal be delayed also, there is no problem. Particularly useful in elderly patients and patients with cognitive impairments. So for patients, this insulin is very useful because if you give insulin and if they don't consume food, then they end up in hypoglycemia. So that can be prevented. Also useful in whom the eating behavior is not known. So just comparison the wide range of patients. Uncontrolled diabetes, both aspart and decrease can be used. Renal impairment, both of them can be used safely. Hepatic impairment, both the insulins can be used safely. Elderly, both of the insulins are safe, and even the pediatric age group, these insulins are recommended. So coming to a case study, it's the end of this thing. So one of you can just answer this. A 42-year-old lady with complaints of fever, generalized body ache for 2 days. She's hypothyroid since 3 years, on tablet thyroid 75 micrograms daily. She's a diabetic for 5 years, and there is no history of dyslipidemia. She was on metformin 2 grams and sitagliptin, and there was no drug allergy. Now she has got admitted with dengue fever, her NS1 is positive and platelets are 70,000 and she's admitted to wards. Her sugar is 233, BMI is 27. She was advised basal bolus therapy. So can anyone of you calculate basal bolus and therapy requirement for her? So BMI is 27. So what can we take as of now? So what will be the total dose of insulin? Sorry?
0.5 to 6.
So 1.5 into weight is 60%. Okay. So how much it is total body? 65. So what is the total insulin requirement? 0.5 into 65. How much it is? Okay, can take it 32. So how much should be the basal insulin? 60. So in the 16, how much should be the candle insulin now? So divided by 655. So candle insulin should be 655 and bolus should be 12. They can be insulin resistant. Cheese. And 50% is 70 of faster, 665 and total 16. So bedtime and pre-meal sugars monitored. Directional dose should be given once based on the blood glucose and insulin sensitivity, and then shows discharge and discharge. So coming to the summary. So advantages of the next generation basal and prandial insulin analogs in patient. It has good reduction in the A1C, overall this risk of hypoglycemia, no risk of nocturnal hypoglycemia also. There is very good flexibility and there is wide range of population. Before the needs and facts. Just 5 slides are there, just about needs and facts of this.
Many times, see, when we visit our ICU, I think the ICU people should also be involved in that, giving this training of sleep. Many times, whenever we go for the round, what are these? Go for the round, it's the same thing. Whatever will be done, it is always they have mentioned training period. And many times we correct it, but again there will be side effect. That is it has been never corrected with all this in spite of going regularly in the ICU. Patients when you do the round, they will follow the same thing. In fact, actually many times we are corrected. Still, even I asked the CV to calculate and write, but still it will be. They mention it is the sliding scale. And even in last this one, mortality with audit, mortality also thing happened, isn't it? Even Maiden has actually asked about very much about the why you use the word sliding. It should be totally banned out of ICU. Sliding state should never be mentioned in any case. And I don't know how it should be corrected. In what way it should be?
We should stop using.
See, I think, in fact, I don't know, Dr. Vignesh here is even when Vignesh is also with even we were doing rounds. The ICUs are most of the time they are managed, and the most mortality which becomes higher when you don't control the sugar. High mortality.
Will reemphasize that
I think we'll invite ICU people who are very much actively involved in treating a patient for an emergency, where there's a more life or saving procedure which they have. That I think we have to emphasize on, rather than just having a training or a seminar like this. There is no point in especially now when we are in BMC and other things where we have only 7 to 8 and HDU, where most of the around 200 patients are managed only with the physician, with less mortality. And with this, I think you have to convey the just with the front.
Thank you.
I just
big scale story. Patients in accidental emergency, problem is you don't access the insulin requirements as per the formula. Once you know what is required, suppose a patient was taking around 60 units of insulin. You put on some simply sliding scales and give 6, 10 and all the parameter you should consider is what was the insulin requirement prior to admission. So after admission, most of the time, sometimes it's hypoglycemia setting, the insulin requirement will be much more. These two things, what is the insulin requirement? If you know that, then you will never put the sliding scales.
And, many times I will explain the situation where patient would have been hypoglycemic, though he is a diabetic. Many times they would have been hypoglycemic when they come to the hospital. And many times, or sometimes, a hypoglycemia with a reactive hyperglycemia, which I think I have one mentioned in many of my patients who have been treated by orthopedics. There will be a reactive hyperglycemia, which they don't understand patient is having a hyperglycemia. And many times patient life has been lost because they don't correct the hyperglycemia. There will be a reactive hyperglycemia, which is a transient, because that itself will indicate a person who is having a diabetes still is having an autonomic nervous system very potent, very strong, and there will be hyperglycemia. Within short time, he will go for a severe hyperglycemia, and that patient would have been died just for not correcting hyperglycemia, which has been happened in even in casualty in BMC. We have seen our PGs would have been given insulin because it is a hyperglycemia, so hyperglycemia, given injection of insulin, patient died. Irreversible damage. That you must always, it is not an emergency, you must assess whenever there is a reactive hyperglycemia.
Few slides here to mix and match. I think I can cover it now. So first myth is the degludec takes long to achieve the steady state. So this is a myth. Degludec achieves steady state in 2 to 3 days. So even it is comparable with the even instant glargine also. Instant degludec attains 70% of serum concentration by day 1 and 90% by day 2. Steady state of instant degludec is reached in 2 to 3 days. So insulin glargine. This is similar to insulin glargine, which injected once daily will reach steady state in 2 to 4 days after the first dose. Steady state once again, the degludec insulin will take 2 to 3 days. So basically the thing is both are, it's not like it will take very long time, and it is comparable with the glargine also. Second is degludec might not give effective control and lead to hypoglycemia and not suitable for inpatients is what there is a myth. So the study, this IDEO study has showed that degludec versus glargine in hospitalized patients. So degludec use in hospitalized patients was effective with better glycemic control. So there have been a number of studies which have shown that degludec is as good as glargine insulin in controlling the sugars and as well as preventing hypoglycemia. So there should not be myth that it is something which is not good for inpatients, because it's a myth that it's only used for OPD patients. IDEO study once again. So degludec use in hospitalized patients was safe with pure hypoglycemia and reduced glycemic variability, as I mentioned. So glycemic variability is very well taken care by insulin degludec. You can see here the fasting standard deviation, that is the glycemic variability parameters, was 45 before and then it was 25. Pre-dinner standard deviation is decreased, hypoglycemia is decreased, and nocturnal hypoglycemia is literally 9 with insulin degludec. Faster aspart for short duration and hence might not cover the mealtime excursions. This is a myth. That is the fastest aspart does not cover the mealtime excursions adequately. So studies have told that the total and maximum exposure for both faster aspart and aspart are similar. So there is takes care adequately the post meal excursions also. Faster aspart and regular aspart is similar. Duration of action, the duration of action is comparable in both arms. In both, it is effective both in type 1 diabetes as well as type 2 diabetes. Fourth myth is owing to its early onset and faster early onset of action, faster aspart poses higher risk of hypoglycemia as compared with the regular aspart. So here it was seen as this I have repeated in the previous presentation. So overall the risk of daytime and nocturnal hypoglycemia is much less in the faster aspart compared to the regular aspart. The odds estimated ratios are quite less. So emergent meal related severe or blood glucose confirmed hypoglycemic effects. So all of these studies, the time duration within 1 hour, 2 hours, all these things. In the faster aspart group, it is much favorable. So lower rate of hypoglycemia between 2 to 4 hours post meal with faster aspart. So there's no risk of hypoglycemia. The lesser risk of hypoglycemia. Any doubts?
Definitely.
Degludec is acting for more than 24 hours, like it's around 36 hours half-life. Then we make it alternate day dosing is one question.
For the pharmacology parameters, you can make it, but still the maximum duration of action is 24 hours. So I don't think so we can prolong it. But the smoothness which it acts and without any excursions is one of the important things, and it takes care of the glycemic variability. So taking all these things once a day is enough, I feel. Any other point should I add?
Yes, sir. So we have conducted studies called the flexible study with degludec, where we have dosed it between a gap of 8 to 40 hours to see if the efficacy is maintained and safety profile. So it maintains the efficacy and safety. But for a patient who is continuously on basal insulin, it is advisable that every day he takes it at a specific time so that he maintains the flat profile. So if he misses a single day, then invariably the steady state level is going to come down. So to avoid that and maintain the basal state, it is advisable that it is taken every day. But if he forgets to take it at a specific hour, he can still take it when he remembers. So that is the flexibility that it offers. So it is better not to advise patients to miss the dose, so to maintain the state.
Any other doubts? Just a couple of minutes waiting.
I'm on the way.
On.
So I would just like to introduce Novo Nordisk to you in the gap when we wait for man to join us. So this company has been in the therapy area of diabetes over the past 10 decades. It was founded in the year 1923. And interestingly, one of the founding scientists was a diabetic, type 1 diabetic, Dr. August Rowe. And in her quest for insulins, she came across this new insulin molecule in University of Toronto in 1921. So she went ahead, requested Dr. Banting to allow her to come out with preparations with insulins in Scandinavia. So that's how this firm was founded. And the journey continues for the past 10 decades with the core focus on insulins. So as you can see, it was in 1946 that Novo Nordisk came out with NPH insulins that are still in use. And we had unlimited quantities of purified insulins, bovine insulins, porcine insulins in the decades of 70s and 80s. Then in the analog genre, so Novo Nordisk has molecules in bolus, basal, premix, and co-formulation as well. And also, Novo Nordisk came up with one of the first pen devices in 1985, the Novo Pen. So I think we have a ma'am here with us now, so I won't take further time. We have an interesting session on critical care management. I would like to invite Dr. Chitra ma'am for the session. I take the bottle and talk. Thank you very much for joining for this lecture. And I'm sure you're all in for a great treat with the lecture with Dr. Chitra ma'am. Hi. In the non-critical insulin use or my faculty to try and see if they are making the right decisions or what. So the small nuances always improve upon and also I think another important aspect of this is how to transition from IV to subcutaneous. That's always should you go overboard or should you go a little less? What to do when you're not sure how today. So opening with the disclosure, this is a Novo sponsored symposium. So you might see too many mentions of Novo related incidents, right? Because this is a sponsored symposium, but we try and stick to science as much as possible. So this is the overall agenda. We will talk about how to manage hypoglycemia in the ICU setting, which all of you all are doing already. Also then talk about what prandial insulins can we choose in discussion to highlight all the points that we discussed. So we'll move to the definition of hyperglycemia in a hospitalized patient. Notice that the definition is vague, right? What does it say? Blood glucose value greater than 140 milligrams per deciliter, and that definition has been made for a reason because it does include people who have a previously diagnosed type 2 diabetes, right? But it also includes a special entity which is unique to this situation, which is stress-induced hypoglycemia. So I'm sure you know what stress-induced hypoglycemia is. Does anybody want to volunteer? Hyperglycemia only during that episode. Before and after is normal. So how do we confirm that? What will happen if you do HbA1c in this situation? It will be normal in stress-induced hyperglycemia. But if your HbA1c is also high, along with the blood glucose, which is high, you make a diagnosis of undiagnosed diabetes, right? So that's exactly why the definition is kept vague like that, which is greater than 140 milligrams per deciliter. If you have an A1C greater than 6.5, you know that this is a patient who has previously, or if he's on treatment for diabetes. You can have very well controlled individuals with type 2 diabetes, which HbA1c is lower. It's also important to ask, are you on any medications for diabetes? So that is the three sections of people who are included. Now, why is it important to address stress hyperglycemia? Does it have any implications on outcomes of maybe the admission for which the patient is with you, right? So irrespective of the cause for hyperglycemia, be it previously detected type 2 diabetes or being detected for the first time, or stress-induced hyperglycemia, all of them are associated with adverse outcomes, irrespective of what the source of hyperglycemia is. And that's why it still becomes our business to make sure that we treat that hyperglycemia. So if you're trying to look at how common is hyperglycemia in ICU settings, this is just one of the observational studies which took a look at 1,000 odd individuals. It is as common as 1 in 2, right? That's exactly why getting a GRBS at admission is important, and maybe one GRBS might not be enough. Maybe again, the second day, third day is something that we need to keep in mind, because it's very common and we do know that it affects outcomes and mortality. And there are many studies. In fact, Dr. Anil and all will recall the journey that we've been through. First, they said in the ICU, very tight glycemic control. Then they said very lax control. And then they kind of reached steady state and they said, okay, moderate control, okay? But without going into the details of the journey, it's recommended that you maintain your blood glucose levels anywhere between 140 to 180 milligrams per deciliter in the ICU settings. Always with the rider that you might need to tweak this depending on the person that you are taking care of, right? So I'll give you some of the examples of how that is to be done. So just focus on the first two lines, irrespective of whether your patient has diabetes or no diabetes. All ICU care patients recommended that you maintain blood glucose level between 140 to 180. So then the next question is, when should you start treating, or when should you think about starting treatment? The threshold is 180 milligrams per deciliter. Again, I'm sure clinical judgment tells you that one value of 180 milligrams per deciliter is not when you suddenly jump in and start your infusion. Maybe one or two consistently elevated values greater than 180 is probably a threshold for you to start initiating treatment. And almost all organizations do agree, except for maybe the American College of Physicians, but they've been quite in disagreement with the rest of the world for a while now. So these are the targets that we spoke about. The in green is the target of 140 to 180 milligrams per deciliter. Of course, if you have a patient who's had a recent episode of severe hyperglycemia, severe hypoglycemia, you do not want them to go low at all, right? Which means that maybe you can move up the lower end to 160 to 200. If you've had one major episode of severe hypoglycemia, it's very easier for you to have a recurrent episode without having any symptoms, especially in the ICU care setting, where we might be using restraint, where there might be tubes which prevent patients from calling out or reaching out for help, where their ability to respond might be obstructed by altered sensorium or maybe sedatives. And that's exactly why this whole threshold is dynamic. So if I have an elderly individual who's on dialysis for CKD, my threshold is likely to be 160 to 200. So at the end of the day, you're the judge, you're the person in charge, and you will know more details than, let's say, I will, because I come in for maybe 10 minutes, and you stay with the patient for hours together. Similarly, the recommendations are made by people who do not probably understand our settings. They probably made these recommendations where there is one ICU nurse taking care of two patients. Right? Those are also factors which will affect whether we'll be able to respond to hypoglycemia or not. So feel free to tweak it, but be able to justify your decision as to why you decided to keep that as the target. So what insulin should we choose? I think this answer is quite clear. IV insulin is recommended all the time in the ICU care setting for many benefits. Some of the benefits are on the slide. But does anybody want to tell me what the benefits are with IV insulin? The minute you turn off the IV insulin, the action of IV insulin stops within the next 5 minutes, 5 hours. 50 minutes. 5 minutes, right? So the half-life of regular insulin given intravenously is 5 minutes only. So if your patient is going towards hypo, all you need to do is stop. Versus, let us say you gave subcutaneous insulin and your patient is going into hypo, that's one of the issues. Second, subcutaneous absorption is erratic, especially when your patient is not hemodynamically stable, which is quite often what is happening in the ICU, right? One of the most important reasons why we stay in the ICU is hemodynamic instability. So if you want consistent release of insulin, IV is the way to go because the hemodynamic status does not affect the absorption or the action of insulin. So it is recommended that we stay with IV insulin during critical illnesses. So these are the indications. I think these will pretty much be the reasons why we might shift a patient to an ICU care. Anybody with uncontrolled diabetes, anybody who has a coexisting infection, hemodynamically unstable, post-surgery or perioperative period, anybody who's requiring high-dose steroids, maybe altered sensorium. Labor and delivery, I think they don't move into the ICU care. They're treated in the labor unit. Also, the unique thing about labor is unless you have type 2 diabetes with labor, if it is just gestational diabetes and labor, usually labor itself is such an intense process that sugars are usually maintained very well and you might not need insulin infusion at all. Unless it is, let's say, somebody who's had type 2 diabetes, the insulin requirement is very high, then you might need to continue IV insulin. But the requirement drops down significantly because the uterus is very active, it takes up a lot of glucose by itself. So moving on to the ICU insulin protocols, many famous names, many famous protocols. But the principle of it all is quite simple, that you keep the insulin going to bring your sugars to target. And once your sugars come to target, maybe add dextrose-containing fluid to the situation so that you maintain your blood glucose levels there. And most critically, in patients aren't eating orally or maybe eating very little or poorly through rice tube. So that's the way to go. The principle is that. So we have one and we understand the principle behind the protocol by itself. Okay, so how do we start an insulin dip? Do you do this 100 units in 100 ml? What do we do in our wards? Sorry? 40 or 49? You do 40 in the 50 ml syringe. Yeah, is that what you do? Okay, we do 49 units in 50 ml syringe, which is again, you're all doing 1 unit per ml, right? Yeah, so that's the standard. So this is from a source where they probably have larger infusion pump sets, but our pump set can accommodate a 50 cc syringe. So that's what we do. What's the most important thing you need to check before you start IV insulin? Perfect. So what is the potassium at which you'll be absolutely comfortable to start? Sorry? Above 4. What is the source for this? Your reference is Harrison. Harrison? I don't have to see. Okay, so
3.3 is more than 3.3
you can start
supplementing potassium.
Very nice, correct. If it is less than 3.3, you don't start at all. Very clear, right? You have to stop and replace potassium, only then can you restart. More than 3.3, you can start, but you will also need to continue supplementation. More than 5.5, you can start without having to start potassium supplementation. Okay. This is from Harrison, but this is under the DKA management section, right? But it still holds good in this section. What insulin will you choose for IV insulin? What do you use usually? Regular insulin. Why does regular insulin make sense to use? Because it's safe to be used IV, right? So what's the half-life of regular insulin if given IV? 3.5 to 5 minutes. What's the half-life of analog insulin if you give it IV? Same 5 minutes. Same 5 minutes, right? So you can use any of the analog insulins or regular insulins, but does it make economical sense to start analog insulin? Does not at all, primarily because analogs, all of its strengths are for subcutaneous use, but theoretically, it is absolutely okay to use any of the analog insulins, but you must remember that long-acting insulins, especially glargine, are not for IV use, right? Only the short-acting analog insulins can be used IV, right? There is some evidence accumulating to suggest that maybe intravenous
analog insulin might be better than regular. So I'll try and present some of that. And once you start your IV insulin, what should you do? Should you check? Should you check sugars? How often should you check? 1 hour, 2 hours, or what we choose? It would depend on the sugars that you start with. If you're starting with sugars which are, let's say, 350, 400, you might get away with checking once every 2 hours. But as you're moving closer to the target, maybe you might need to do hourly. Also the sensorium of your patient. If your patient's sensorium is obstructed, you might need to be intensively checking it every hour. Okay. And when will you stop it? Will you decide to stop it? When your patient is probably going to be switching to oral intake, that's when you transition to subcutaneous. And you also make sure that the metabolic parameters are all corrected, that there is no acidosis, you've taken care of all of that, and then you can switch to subcutaneous. All right. How do you now choose the dose? Do you all have a thumb rule that you follow? There's one thumb rule here, but is there anything that you follow? 100%. 0.1 unit per kg per hour. That's your infusion rate, right? Do you give bolus? Do you give bolus in the setting of decay or in all setting? In the setting of decay. Does the new Harrison say that you must give a bolus? Do you have it somewhere on your phones to check? Okay. So this bolus thing was what has been taught for years, right? But the concern with the bolus insulin has been that, especially when it is children, they've noted that if you're giving bolus insulin, you're increasing the chances of a cerebral edema, right? So it is now recommended that you don't give that bolus first push of insulin and just start the infusion. Can you verify if Harrison still says that you must give bolus? We had a discussion in our department about a few days ago, and we all concurred that they've done away with the bolus. So so you can start with the rate that he shared with us, 0.1 unit per kg per hour. So roughly, if anybody is weighing around 80 kgs, how much will that be? And by that, 8 units, right? So that will be the lowest that you can start. There's another thumb rule here, which is dependent on the blood glucose level, which has been checked for that particular patient. Like, for example, if your patient's blood sugar level is around 250, you and I both know that 8 unit per hour is a high dose, very, very high dose, right? It's a very high dose, right? So you can use the glucose reading which you got at that moment also to guide you the infusion rate. You can just say whatever sugar reading you get, divide it by 100. Whatever you get the number, round it off to the closest 0.5 and start. Which seems to take into account, the sugars, and then take it from there. So if your somebody's blood sugar levels are, let's say, 250, around 2 to 2.5 units seems reasonable to start as compared to, let's say, 8 units based on weight by itself. Okay. So you start that. If your patient's blood sugar levels are high, you just continue normal saline infusion dependent on all the other factors which dictate your fluid rate. Your bosses of that decision than us, right? Depending on whether there's fluid overload, dehydration, all of that. But when blood sugar levels reach target, make sure you add dextrose containing fluid. Keep the insulin going. Why should we do that? Why can't we just turn off the dextrose containing fluid, turn off the insulin infusion, and just reduce the burden on the care team? Why should we do that? Because the minute we stop IV insulin without overlapping it with subcutaneous insulin, we'll then go yo-yo like that. So that's why always very tempting to stop the insulin infusion. We do see that happening all the time, right? Stop the infusion, stop everything, but that's not the way to go. You need to keep it going, maybe reduce the rate if you're uncomfortable with, so much of insulin going, but add an dextrose containing fluid. What happens if the sugars are not coming under control? What do you do then? You have to increase the insulin infusion rate cooperating with the blood sugar level. This is what is referred to as an algorithm method to decide the infusion rate. So they will have let's say 4 algorithms. You start with algorithm 1, it's arbitrarily decided. Okay, when you say if it is between 180 to 200 control algorithm, there will be an algorithm, right? In some way, they already say that it is short. If your patient is receiving steroids, but this is essentially a format for nursing team to increase. What do we do here? There, which we edit. We don't go from 1 to 2. We just change the infusion dose for that particular patient, right? So that's how you bring your sugars under control. Next, here comes the tricky part of how to transition from IV to subcutaneous. So which are the points where you decide to shift from IV to subcutaneous? One, you either start oral feeds for your patient, then it makes sense to switch to subcutaneous. So if your patient is stable enough to eat, is hemodynamically stable enough to accept subcutaneous insulin. Or if you're going to start NG tube feeds or rice tube feeds, or if you're going to start TPM, right? So those might be situations where you switch to subcutaneous insulin by itself. There's one important step before you jump off. What is that? Yeah, what is overlap? Explain the principle of overlap. You have interns here, right? You are an intern. Yeah, we have interns. Yeah. Go ahead. When should you overlap? There will be rebound hyperglycemia, right? Which we don't overlap. Correct. So how do we overlap? Is there rebound hyperglycemia? Because as soon as you inject subcutaneous insulin, does the insulin level rise immediately? No. There's a lag of how long? At least 30 minutes if you are using regular insulin. Shorter duration if you are using analog insulin. But there is always a lag, right? So you can't turn off your IV insulin suddenly and switch to subcutaneous. So you give the subcutaneous insulin, continue the IV insulin at least for an hour, maybe even an hour and a half. Then you stop the IV insulin so that there is no rebound hypoglycemia as pointed out. Okay. So this might be one situation where analog insulins might be doing better than regular insulins in terms of how many hours you need to overlap, right? That might be a key difference in the ICU setting. Okay, so now if you're going to switch to subcutaneous, you also have to decide what's the dose of insulin that you're going to give. What do you usually follow? You calculate the total dose required for the last 24 hours. How do you do that? Do you add 24 hours? You can do that, or you can take a representative time, maybe 8 hours multiplied by 3, or take 6 hours multiplied by 4. But I think you should be adding that for 24 hours. So you catch the highs and the lows because the insulin requirement might not be the same through the day, right? When will the insulin requirement be the lowest during the day? Between 12 to 4, right? The middle of the night, your insulin resistance goes down because all of your counter-regulatory hormones goes down. So your insulin requirement is lesser. So I think you should do the entire 24 hours if you like to add. I'm validating my residents add, and then I just take that number. Okay. So once you calculate the total daily insulin dose, what do you do from there? Always reduce by about 10%, right? This is you can even reduce by 20%. And that whether you do 10% or 20%, again, You're the boss who decides because you know the patient. If it is, let's say, somebody who is 35 years, right, obese with an infection, right, you're likely to reduce only 10%. But if it is somebody who's frail with acute on chronic CKD, whether his food intake will be consistent or not, reduce by 20%, right? So go with your, listen to your gut instinct, you'll always be right. So reduce that dose by that much, that number which you get will be the total daily dose now, which you have to split into the subcutaneous dose. Ideally, you should split it into 50% basal and 50% bolus, right? I think if medicine learns this one point, endocrinology, there's no need for endocrinology to come into IP rounds at all. It's same for cardiology as well, right? So what is usually missing after the ICU care and the IV insulin, which you manage like bosses, is the transition into subcutaneous. The basal section is one which is missing in the prescription. And that's exactly why everybody wakes up with fasting sugars which are high. Now this 50% basal is not entirely true maybe for our ethnicity. Our ethnicity maybe requires 35 to 40% basal insulin and maybe 60% bolus insulin because all of our meals are carb rich. So when you are giving, and let us say you calculate the dose, let us say somebody required 100 units infusion, you reduce by 20%, it became 80 units. Half of that is 40 units. 40 units of basal insulin in one shot is way too much. You and I both know, right? We both know that's too much, right? So that's something again we'll have to respond to. Go low when you're in doubt. Nothing wrong, right? So maybe 30 to 35% basal, and the other 60 to 65 divided into 3 doses and give it with each of the meals for bolus insulin. Bolus insulin is called bolus because it comes, acts for a few hours and goes down, just like how the sugar rises right after you eat a meal. Whereas basal is continuous like that, flat, mostly without any peaks to take care of suppressing the hepatic glucose. Okay? Both of these are crucial points of the basal bolus regimen that you put the patient on. It's okay if your sugars are bouncing up and down. It's okay if your sugars bounce down. Don't skip a dose. Okay, so this is another thing which we see in the wards, right? So pre-lunch, a patient's sugar is 88, right? And they call you intern. What will you do? Do they call interns? They never call us. All the BGs, I don't know what's going on. So what will you do if sugars are 88? What should you do? Ask the patient to eat first. Ask the patient to eat first and then give your insulin. Even if it is regular insulin, you can go ahead and give your regular insulin. You can give same dose, or you can maybe reduce by 2 units, or 4 units, or 6 units, but never skip the dose. Right? So this is another thing which we commonly see. You skip, and then the next reading is 300, and then you add 8 units to the dinner dose, and then there is post-dinner hypo, right? So although it seems counterintuitive, don't skip the dose. Continue the dose, reduce if you need to, but don't skip the dose. Okay? Is that clear? Okay. So can you name some basal insulins? What basal insulins have you prescribed? Great. Anything else? Sorry? Detimer. Okay. Then? Okay. Then you forgot another one. NPH? NPH. It is not basal insulin. It's 100% basal insulin. Okay. Yeah. 100% basal insulin. Okay. All of these are basal insulin. Can you tell us all the bolus insulins? But you all become analog doctor now. Nobody is talking regular insulin. Okay. Regular insulin aspart is from what? Blue medicine. Anything else? There's a faster acting aspart. There's a fast acting aspart called yes. Okay. So these are all the options which are available. What is the most important thing which predicts which insulin a patient gets? Affordability. Whether they are on insurance or whether they're paying out of their pocket, right? So yeah, it's a sad state of affairs, but that's mostly how it works. Okay. Although there are differences between the two, and we would love everybody to be on analogs, right? All right. Is this clear? Is this step clear? Total dose, reduce by 10 or 20%. Definitely divide basal dose 30 to 50%, and the other 50% break it into 3 and give your bolus. If you are worried about post-dinner hypos, give lesser dose for dinner, no problem. Next day you wake up, review the sugar values to adjust accordingly. Is that right? So there is no basic bolus regimen without basic insulin. So 3 times bolus dose will not be able to keep your sugar under check at all. Right? Is that clear? Okay. All right. So what branded insulin would you choose in critical care? So this is a study which tried to look at which insulin was given, okay, IV aspart, and what they saw was that when they gave IV analog insulin, the drop in the blood sugar levels was faster. Also, the amount of insulin that you required was lesser, and the ability to recover from a hypo was better, right? But like I say always, it's very important to keep our minds and eyes open, understand the overall view of what's going on. These might be parameters which are important in a small subset of people who might require it, but overall, in general care, managing hyperglycemia will give you huge dividends than these small delta numbers, right? So again, perspective is important, right? So these are the, let us say, benefits offered by analog insulin in IV critical care setting using IV aspart. And this is again a study which was published from India recently, trying to look at the benefits of IV aspart insulin over regular insulin, but there was lesser dose required, and also there was a faster recovery during hypoglycemia after we stopped the insulin or aspart insulin. Now, all the other bolus insulins are also approved for use in combination with the various fluids intravenously. And we now also have another form of analog insulin, which is the faster acting aspart. What is the difference between this insulin and, let's say, the normal aspart, which is more rapid? First time it is highlighted. So you can even give it right after meal. Of course, novorapid also can be given right after meal, but this can even be given 20 minutes after meal. And in the critical care setting, it might add some advantage, primarily because you're not really sure whether they're going to complete the meal or not. So you let them eat their meal, complete their meal, and then you assess what percentage of the meal they've eaten. If they've eaten as much as they normally do, give their normal dose. If they're eating lesser, you can always reduce dose. Because one of the main intentions along with controlling hyperglycemia is also to make sure that you decrease the episodes of hypoglycemia. It carries equal weightage and you're trying to improve outcomes for people. Hypoglycemia in the critical care is also associated with worse outcomes. And this is again a slide which was done specifically to study that, where they gave faster acting aspart insulin, which is called as PAS, 20 minutes after the meal was taken, and compared it against aspart insulin, which was given at mealtime. And you see that there is better postprandial sugar control as compared to the one which was administered before. And looking at the risk of hypoglycemia, again, the risk of hypoglycemia is better with the faster acting aspart version, both overall and long term. So it can be given 2 minutes before meal or 20 minutes after meal, and it need not be used always in critical care setting. It's also something that can be used otherwise. Lunch is the meal I think everybody struggles with, trying to take their bolus dose, and especially if you're working. I think this offers them the advantage of taking it just before or even right after. If they're having a social lunch with their team members, they can even take it right after they finish their lunch. So we'll move on to a case discussion. I'd like you all to participate and tell me what's going on. So there's a 50-year-old lady who's had diabetes for 8 years. She's on MPA, metformin, and insulin Regulate 80 units per day. So Regulate is what insulin? Not acting, this is insulin. Perfect. All right. So she's presented with breathlessness, fever, and cough, and also smell. Of course, you know what the diagnosis is. Her SpO2 is 84%. Don't we all hate the diagnosis? I was sleeping well. She was shifted to the ICU and she was put on non-invasive ventilation, and our blood glucose now is 330 milligrams per deciliter. Ketones are negative, there is no acidosis, right? That's a good sign. So now do we have to stop the empagliflozin and metformin? 100% we have to stop, right? Because empagliflozin can increase the risk of ketoacidosis. Metformin has to be stopped in any admission. Forget an ICU admission, so both have to be stopped. Just basal insulin is not going to be enough because she's now allowing this medication. So we're now going to shift to IV insulin. With the glucose goal of 140 to 180. So if our blood sugar is 330, what will be the rate to start? Around 3 units per hour. So that's what was done. Around 3.5 units per hour was started, and patient was given. I don't think you should give dextrose containing fluid right now, right? I think you should just give normal saline, keeping an eye on status, right? Especially in COVID, they were suspecting, I don't think you should, right? You're not supposed to give too much of fluids, so I don't have 100 ml per hour is ideal for this lady. We've not assessed renal functions also, so I would go a little carefully with the fluid rate itself. The algorithm, which is to be used, and then we calculate dose, checking sugars every hour. Now on day 5, your patient is stable, doing all right, but was still on IV insulin for 5 days. Now we've calculated the total daily dose as 40 units per day. Now the pulmonologist says we can shift to HDU and we can start oral, and then how do you go about breaking the total units into a subcutaneous regimen now? 20 and 20, 50% basal and 50% bolus. So she was already on degradant, so you can put her on 20 units of degradant. The other 20 units, you break it down into 7, 7, and 6. Because dinner we want to go easy, and we started CS, which is the fast acting as parts of bolus insulin. Because she's in the HCU, we still don't have people with her, right? It's still COVID. So she's going to be eating alone. So she won't be able to reach out and grab her glucose tabs if she has hypo. So she can finish her meal and maybe take her insulin after that. So on day 7, she had gastritis and vomiting. So she had one episode of at that time. So then parenteral fiasco was withdrawn. RT feeds were started at that point. When RT feeds were started, the spikes in sugars were happening. Sugars were going up to 250 and more. What would you want to do now? Do you have to stop the basal insulin or continue? You have to continue the basal insulin. Parenteral insulin maybe 4 times to coincide with the feeds, right? And that's the advantage of insulin, because their duration of action is also shorter. Now, regular insulin can sometimes up to 6 hours, but the short-acting analog insulin stop acting by about 4 hours. So that's what was done. 4 shots of PS insulin was added with each of RT feeds, and that's how the blood sugars were controlled. So hyperglycemia in the setting of the ICU is very, very common and is associated with worst outcomes. And you are the bosses of treating individuals at the ICU. So it's absolutely imperative that you ask, was the GI list checked, right? So at admission itself, it should probably become part of the protocol. Even stress-induced hypoglycemia needs to be treated. In the ICU setting, IV insulin is the way to move forward. Only thing to check before you start is potassium levels. Start your insulin infusion whenever you are not feeling all right. Go at a lower dose, nothing wrong at all. Some of your faculty will come and yell at you if you start at a lower dose, right? Now, so go easy if you're in doubt. Titrate as frequently as you need. When you need to transition, follow the rule of 50% basal and 50% of bolus broken into 3 times. All right? You have any questions for me? I hope we learned something. No questions. No questions. Go ahead. In the ICU itself, is it? What? A difficult question is asked. Okay. So I think it's a very difficult question. So I'll maybe take you through the whole. So now you've discharged this patient home. When you discharge her home, what will you send her on? You'll send her on basal bolus. You have to send her on basal bolus only. Maybe reduce the dose by 20 to 30%. 20 to 30% because the minute they go home, everything becomes better. They move a little bit more, their stress is lesser, they sleep better. It's very, very common for people to go into hypo on the second day or the third day, right? So go reduce dose by 20 to 30%, send them on basal bolus. Maybe at the first follow-up, which is 5 to 7 days, you take a look at their sugar chart and their insulin readings, right? Now, whether you'll be able to switch them to OHAs immediately or whether you can change them to premixed insulin or switch to OADs and basal insulin will depend on the sugar values and how much of insulin they are on. Like this morning, an elderly gentleman with decompensated liver disease admitted with sugars of 700 and odd about 2 weeks ago, who was discharged home on close to 120 units per day, right? But slowly, gradually, over just 10 days, his insulin requirement has now dropped to around 34 units in a day. So, so 10, 8, 8, 0, 0, 8, something like that, right? And we all know that basal bolus insulin is difficult, is taxing for the entire family. Somebody has to be there at home. It's usually a woman, right, who will be asked to be office and mind to go and check sugars and give insulin, right? So now I transition to premixed insulin. Premixed insulin is 2 shots per day. Somebody has to maybe coordinate the shot in the morning and in the night. You just have to make sure that the patient eats lunch on time. That's it. From premixed insulin transitioning to OAD is so much more easier than from basal bolus itself, right? Along with this, while you're shifting to premixed insulin, of course, in my patient, I didn't add an OAD because he has ECID, but otherwise, we'll be able to add metformin around 500, titrate it up, see how it is going. So next visit, maybe 3 to 4 weeks later, they might be on a low dose of premixed insulin, maybe as long as it's, let's say, these are thumb rules, okay? 50 units per day, you might be able to take them off insulin. If I'm wary, I might take just the night dose off and add OAD there. Usually DPP-4 inhibitor or metformin combination, or maybe that with a small dose of sulfonylurea. And next visit, remove the morning and add the sulfonylurea there, right? So that's how you transition, and that's really a dance. It's really a dance. Most important factor there is whether your patient is still checking sugars. If you don't have any idea or any data points to work on, it's very difficult to transition, right? But mostly you should get them to stay on insulin while they get discharged. But very good question. Huh? This was the same question I asked Dr. Krishna Shishadri when I was an MD resident, when he taught us how to manage hyperglycemia in the ICU setting. Other questions? Okay, I thank you, Dr. Again? Okay, Dr. Archana. Good to see you. I love your frog.
Thank you. So we have come to the end of today's sessions, and from now on, we'd like to thank Medicine Department for giving us this opportunity to conduct the scientific session. I'd like to thank Mr. Ramaiah sir and Shin sir for excellent sessions, deliberations, and discussions. And we see that it was quite interesting and informative for you. So we would now request you to join us for lunch at Skills Lab, and the faculty can proceed further, but the students have a post-test. Sir, do you want to add anything finally before we close the session?
Thank all the participants, PGs, interns, and faculty, seniors of our department for giving us the opportunity to conduct this training session. So thank you all for arranging, sponsoring this event. Thank Chitra ma'am for a wonderful session on ICU management of hyperglycemia. It was very enlightening to all of us. Thank you. After the post-test, lunch is in NBC room. Skills Lab. Please have a